Dear viewers, welcome you all to our show, Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing mask and keeping distance with each other, and definitely by getting vaccine. Dear viewers, today our topic is post-traumatic deformities of hand bones managed by Elizar. We all know that all patients want functional and cosmetic limb. They don't want any deformities. Actually, they don't accept any deformities, but it is very difficult to recover the deformities as because of we all know that it is a very challenging thing. But where there is impossible, there is possible by Elizarov. We can manage this sort of deformities easily and magically by the magical Elizarov. And dear viewers, today our speaker is a very honorable and academic person, Professor Natalia Shikalova from Kurgan, Russia. I would like to request Professor Natalia Shikalova, ma'am, to join with us. Ma'am, welcome to our show, Orthopedic Solution Academy.
Good day, dear colleagues. I am very glad to see you in this site, and I will speak about problem of the hand. Thank you.
Thank you, ma'am. Thank you very much. Dear viewers, we have three academic experts with us. One of them is Professor Novikov sir, the high academic person from Kurgan, Russia. I would like to request Professor Novikov sir, you have already joined with us. I would like to introduce Professor Novikov sir to our program. Professor Novikov sir, please say something. Thank you very much, sir, for joining with us. Dear viewers, we have the legendary Elizarov surgeon of Bangladesh, Professor Mofakkarul Bari sir. I would like to request Professor Mofakkarul Bari sir to join with us.
Thank you, Tanvir, for introducing me. I'm very happy that we have a very learned two speakers, Natalia Shikalova and Novikov Konstantin Igorovich, and at the same time our junior colleague Shamsuluddha. Thank you again.
Thank you very much, sir. Dear viewers, we have another enthusiastic academic expert from Patna, India, Dr. Shamsul Huda sir. I would like to request Dr. Shamsul Huda sir to join with us.
Thank you, Dr. Tanvir. Good afternoon.
Good afternoon and welcome to our show, OSA, Orthopedic Solution Academy. Dear viewers, we don't want to spend any more time as because of everybody is waiting for our presentation. Now, I would like to request our honorable speaker, Professor Natalia Shikalova, ma'am, to share her screen and start her presentation. Professor Natalia Shikalova, ma'am, please.
Mm-hmm.
You can start. Just a moment.
Mm-hmm. 1 minute. Good day. I speak about post-traumatic hand bones deformities and their correction using Elizarov method. Next slide. Distribution of united hand bones fracture.
Ma'am, please share your screen. We can't see your screen. Please.
Just a moment.
Yet not, sir.
And now?
No, not yet, sir.
Now?
It's coming. It's coming. It's coming. Yes, sir. It's okay. Perfectly. Perfectly okay, sir. Please.
Start again. Sorry.
Okay. First slide. We made this presentation with together Professor Shevtsov. And distribution of united hand bones fracture. First, without disorder of the shape and functional of hand and fingers, not intended for surgery. Two groups without disorder of function but with disorder of the shape. Operative treatment is performed according to the patient's desire. Third group with disorder of shape and function of hand and fingers after diaphyseal and intra-articular fracture and with dislocation and shortening when then operation is indicated. Currently, orthopedic and trauma surgeon can see several techniques to treat this pathology. First, the technique of intramedullary osteosynthesis with the applications of titanium nickeled half pins. Two, application of our mini plates. They can be used for osteosynthesis of the hand bones is in diaphyseal fractures. But intra-articular injuries, osteosynthesis joints, stiffness develops, which is caused by inavailable injury of a capsule and ligaments. 3. The technique of extrafocal osteosynthesis within external fixator. Our materials and methods. Treatment results of 61 patients aged 5 to 55 years with malunited hand bones fracture have been analyzed. Males prevailed for 95% and women and age from 19 to 40 years. Slide with the characteristics of clinical group. Patients distribution according to open or closed hand trauma in the history. We have patients with close trauma of hand and company hand pathology. Malunion with neglected injury of flexors, 31%, and big scars of soft tissue, 26%, and contracture of joint, 11%. Next. Admission after trauma, admission time after trauma. Большинство пациентов. More patients with trauma with more 2 months after trauma. Next. Distribution of injuries localization. More patients have a problem with fifth metacarpal bone. And in the slide, we can see modern wire fixation, modern mini fixator of Ilizarov Center in the slide. Next. And we patients делите разделять на группы. Не делить это удалить. Делить. We have several groups of our patients. The first group have only corrected osteotomy. You can see on the slide deform the bone in this deformed bone before operation. In the operation osteosynthesis mini operate of Ilizarov and osteotomy. You can see the, osteosynthesis and osteotomy. And after osteosynthesis, partial osteotomy and remove deformation of this bone. Clinical experience, patients with problem fourth and fifth metacarpal bone, malunions and deformity of this bone before operation. Hand photo of hand before operation. We can see deformity of these problem bones, and we made operation application Ilizarov frame and osteotomy. Hand after operation. We not have wound scars and result after remove Ilizarov frame. And scheme of surgical intervention with rotation deformity correct. You can see deformity, rotation deformity of the bone before operation. Suppose of mini Irizarra frame 1 and 2, and after we made the osteotomy. After osteotomy, we made rotation and normal with view of after operation, after correction of deformity. And a clinical case, girl of a little girl, deformity, rotation deformity of second finger. You can see after treatment fracture, proximal phalanx, Irizarra frame, osteotomy, and normal view of hand and finger, and result of the treatment. Next group with problem in the proximal interphalanx joint, fracture in the ocular fracture, and we made Irizarra frame 2 and osteotomy and the result of the treatment. Os finger is right, axis finger is right. Two-group correction osteotomy by gradual destruction. Big problem with the fourth and finger and dislocation fragments of these bones and very shortening after trauma. In first step, we made osteotomy and osteosynthesis by Irizarra frame, and we made destruction without the fragments of the bone, fourth and the fifth, and result. Three groups: osteosynthesis of injury tray with near-boring joint contracture correction. Next, patients with the diaphysis malunion of first metacarpal bone with angulation, flexion, dysmogenous contracture of fourth finger. Fourth finger, we can see big scar, and deformity first metacarpal bone. In operation, we made the osteotomy first bone and made the right osseous on this ray, and plastic scar, and fixate Irizarra frame second finger, and result of the operation. Patients, next patient with many malunions, these and defect, total defect, fifth metacarpal bone, deformity, this race, and big scar. This picture before operation. Operation, we made the osteotomy, third, fourth metacarpal bone, destruction, osteosynthesis, and plastic fifth metacarpal bone, free flap with bone, and the results after operation. Two groups. Fourth groups, Leitinen with simultaneous correct finger angulation on the regenerate. Schema of osteosynthesis after operation, we made Leitinen this problem finger, and we узел, joint of for correction deformity and after deformity and result with the Elizarov frame. And clinical case, patients with congenital deformity, clinodactyly of medial phalanx and shortening first finger, osteosynthesis, lightening, and a result of operation, and X-ray after operation. And big problem without absent first ray, absent fourth, fifth, fourth fingers, not functional in right hand, very young woman, and a very big problem with the hand. And this I made the first ray, politicization for a second metacarpal bone, politicization and plastic with use of soft tissue on the abdominal. Next patient's problem, similar problem too, without first finger, thumb, fourth, fifth finger, politicization thumb of proximal phalanx of second finger, and fixation with the Elizarov frame, and result in the finish operation. And our complication in our practice: infection 3 case, dermatitis 6 case. Treatment result, we receive excellent result in the 33%, good 30%, and satisfactory 70%. Conclusion: transosseous osteosynthesis by mini fixator in treatment of the hand bone malunions is different from intramedullary and on-bone osteosynthesis. Transosseous osteosynthesis help to eliminate any long hand bones displacement and to do stable fixator of bone fragments. To solve problem of near-bone joint contracture correction if necessary. Besides, Elizarov mini frame allows to perform early functional rehabilitation for hand without violation of injured bone stability. Thank you very much.
Thank you very much, ma'am, for your excellent presentation. And now I would like to open up our field for the academic expert. First, I want to go to our Honorable Professor Mofakkarul Barisa, to say something about the presentation and about the deformities of the hand also. Professor Mofakkarul Barisa. Sir, yes,
you can hear me?
Yes, sir, we can hear you, sir.
First of all, I would like to congratulate Natalia Shikilova for giving a very good idea regarding the deformities of the hand bones by mini Elizarov. She rightly mentioned regarding the deformities, the AO group, they are doing mini osteosynthesis by mini plates. And I did also this kind of operations with plates and screws, mini plates with screws. But what happened then, after that, I always saw that you are getting, limitation of movements of the small joints. As for example, in the proximal interphalangeal or distal interphalangeal joints. Those who don't have any idea regarding the mini Ilizarov, they cannot even believe how you can go through it. You can get a very good, fantastic cosmetic and functional results by using this mini fixator. The basic idea, if you have in your mind, then you can go for this kind of mini Ilizarov mini fixator. And she rightly mentioned regarding the, she classified the group 1, group 2, group 3, group 4. And at the same time, finally, she mentioned the problems of the contractures of the small hands. And I face difficult problems when I go for the policization of the hand. It is sometimes I face difficult. I would like to draw the attention of Natalia Shikilova. Policization, if you can explain how you can do that will be better for all the listeners. And she rightly mentioned the deformity correction, and by putting the mini fixator, you must go for osteotomy. And when you are going gradual osteotomy, how much angulation you can see, then you are going for gradual, and equally how much angulation when you see, and you can do it acutely. This is my question. Otherwise, you explained everything very nicely. This is a fantastic method by mini fixator. Even you don't need to go for open up. Whenever you are opening anything, you will get adhesions all the time. So thank you very much, Natalia Shikilova, for giving us an elaborate description of all groups of the hand-bone deformities. Thank you again.
Thank you very much, sir.
Мария, твой вопрос, как быстро устраняем?
Да, нет, мой вопрос, я сейчас говорю, вот когда угол, сколько это медленно надо, значит, сколько угол вы можете, но 10, 20, 25, одновременно до скольких угол можно делать, и постепенно до скольких угол, вот такой вопрос.
Если позволяют мягкие ткани, то сразу. Вот это зависит от мягких тканей, от напряжения сосудисто-нервного пучка.
My question was. My question was, how much angulation you can go acutely, and how much you can go for gradual distraction for correction of the angulation? What is the limitation of the angulation?
Yeah, colleagues, I am doctor for long bone, and I'm happy because many years I work together shoulder to shoulder with this is great surgeon, Dr. Shikilova. And when we talk about long bone, usually we never go more than 20-25 degree. Why? Yes. Because soft tissue give us limitation. And this is usually we talk about varus deformity. If the valgus deformity, we never made acute correction. With short bone on the finger, this is depend on soft tissue. Sometimes we have deformity near 90%. Могу сказать, что 90%. And if condition of soft tissue is good, blood supply, blood vessels, skin is good, possible acute correction, big deformity. If soft tissue around of problems bone, very small deformity, but soft tissue not give us permission, we will do this correction step by step. This is depend of case.
Thank you. Very good description.
But usually, just now, Dr. Natalia says, usually we finish correction in operation theater.
Okay, this is good for the hand bones. So this is the message for everyone.
Sometimes we add plastic surgery immediately, simultaneous, because just now our result is more better, because same moment Dr. Natalia, plastic surgeon, and she start with plastic questions. When finished everything, they apply of mini Elizarov frame. And like me, I am doctor for normal Elizarov device. And mini Elizarov give very great situation when after surgery, surgeon can continued and finished all of deformities, all of problems with the short bone. And many times she is a plastic surgeon, but more very big amount of patients she never open, and she not to do big scars. All of our treatment is closed.
Collaboration, plastic surgery, and traumatologist, orthopedic is a beautiful future of medicine. Collaboration, plastic and orthopedic is a very good. Understand? Okay.
My second question. Второй вопрос. На основании чего I'm talking with the Russian, then I will go for English. На основании чего вы говорите, это отлично, это хорошо и удовлетворительно? Какие критерии? Question is, on what basis you go for excellent, good and satisfactory result?
И эстетика, и нет рубцов, это отлично. Нет осложнений.
And excellent result. Beautiful view. Aesthetic. This is first. But first, this is function. First function.
Good function.
Okay.
Without complication.
Without complication.
No. And if patients speak me very good, patient, it's
important.
Important. What say our patients for us? It's beautiful. Patients ask me. Beautiful.
Because sometimes surgeon is satisfied, but patient not satisfied. And very important, good view, aesthetic functional result, and opinions of patient. This is excellent.
Excellent. Good.
Good. Maybe problem aesthetic view. Maybe problem little contractive joint of finger. Maybe, and it's not good. Satisfactory, maybe big contracting, big, but you must consolidation of problem bones, and not beautiful view of the hand. And we must make rehabilitation of the operation must be, and maybe several times of rehabilitation. Exercise, magnetotherapy, ultrazvuk, massage, and functional every day, 5-6 times in day. With no smoking, and no please, not cold water hand. It's very bad for hand.
And can you suggest for washing with the vodka?
No.
Only like application. Only application.
Only application. Okay. Thank you.
Thank you.
Very good explanation. Okay.
Thank you, sir. Sir, I have one question, sir. In case of finger, in case of corticotomy, where will we give the incision? As because of we all know that the vessels and nerves go parallel to the fingers from this side. Then where will be the incision for corticotomy in case of finger? My first question is.
Где разрез? Барри, вопрос.
Да.
Где разрез, да?
С какой стороны разрез вы делаете, когда делаете остеотомию?
С какой стороны делаете? С какой стороны?
Какой стороны?
На выпуклой стороне, где больше мягких тканей.
না выпуклой. যেখানে হলো তোমার concave side যেখানে soft tissue concave side you can make a incision and then go for osteotomy.
Okay. Is it in the palmar aspect or dorsum aspect?
What сюда или туда?
Нет, стила,
Dorsum, dorsum, here. Not here, not this.
Not this, no.
Not palmar, not dorsal. Okay, clear?
Clear.
Then we have to pull out the extensor tendon first. Then we have to do the corticotomy. Is it the way?
No. Extensor you not to need just near the extensor tendon, this side or this side.
Yes,
Don't go for the whole aspect.
Radial or ulnar, or radial
Side, radial side or ulnar side. You understand? Either
Yes,
this or this. It's okay. It's good.
So then, what will be the safe zone for wire insertion in case of fingers? Very basic question for our.
No. Corridor. Безопасный коридор. Class visual. Dorsal is very safe here.
Yes,
Dorsal.
But this tendon of extensor,
Yes.
we must отодвинуть как. Remove.
You just push your tendon, extensor tendon, and go from the dorsal side. Very easy. You don't need to afraid of that.
And osteotome, very little. Osteotome.
Small.
What is
Very
the size
small.
of the osteotome? What is the size?
4 or 5 millimeters.
4 5 millimeter mm.
Да, yes.
Osteotome, very small. And we are using that also. Good. 4 5 millimeter.
We cannot put the wire. Can we put wire from this side or from this side?
Yes, you can put wire from this side. You just make an angulation and then you bend it. You can show the picture fast. The picture you can show they have a good picture. Second slide, probably second slide.
Just a moment.
So you go from this side, then bend it 45-degree angle. Both the wires. Then it gives stability. এখন দেখাবে দেখুন ভালো
You can see osteotome.
Barry, just now you can see full screen.
No,
sir, no.
You show your screen.
Sorry. We don't know. Without. And now.
No. Where is Andrei?
Andrusha.
Andrusha is Pete.
Нет, не спит.
Just a moment. Включи, пожалуйста. Презентацию.
Natalia Shigalova is a fantastic hand surgeon, plastic surgeon, very beautiful.
Да.
ও এত সুন্দর কাজ করে।
I have специальности. Four специальности. Surgeon, dermatolog, plastic, and organization of здравоохранения. Healthy.
দেখছো একটা স্লাইডে দেখালো সবগুলো দেখো osteotome.
I think it is in the first or second slide.
Second slide.
You can see this place of osteotomy. This.
Place of osteotomy.
Видно?
Yes. Видно, yes. No, вот вначале у вас есть, там как вы делаете вот такое положение, в начале есть, еще дальше, в начале. Во. See, look at this. Bending of the wires. You see, you can see, you go from both sides, then you bend the wire.
This bone of metacarpal.
This is the bending, see? This is the bending of the wires. This is the bending of the wires.
Dorsal hand, only dorsal.
Only the dorsal, you can see from this side, not from this side. Volar aspect, no. That you just put the wires, then you bend and fix it with this nuts and bolts. And this is your angulation. You can put the hinge here. Whenever without hinge you can do straight. No hinge you don't need. Then see, this is a Y-shaped regenerated bone. This one, okay, accurately corrected. Even 90 degree you can correct. See?
Yes, sir.
Okay, it's good.
Sir, in case of the lengthening of bones, when we'll do start the destruction, is it in the same pattern, just like long bones, or any other different manner there?
Many these are 0.25, 0.75, even 1 millimeter, just like an adult. In case of tibia fever, here is size is small. That's why you can start 2 times or 3 times.
Barry, dear colleagues, just now Dr. Shikhaleva has another lecture, another webinar after 3 minutes.
In Russia.
Okay.
In Russia. Can we leave?
Okay.
Because just now start webinar with Moscow.
One question from Dr. Shamsuludda, sir. One question from.
One question. So,
just a short question. Thank you, Dr. Natalia, for a wonderful talk. Ma'am, I have a question that besides severe contracture, if there is rheumatoid hand and you have subluxation of the finger joints with deformity, how do you handle the subluxation of the joints along with deformity correction with mini Ilizarov?
Luxatio.
Да.
Luxatio.
Rentgen control, X-ray control, and вы должны регулировать эти рентгены.
And you must to do surgery very intelligent, very delicate. If before surgery patient haven't subluxation during the treatment with correct position of device, mini device, we never have subluxation and amount of lengthening. Величина удлинения, да? And usually each сколько раз в неделю, 10 дней. Once in 10 days must to do X-ray control. And if we feel problem will come, we immediately stop.
So, do we have any slide to show how to correct deformities in the joints, metacarpophalangeal joints, in rheumatoid hands, or in the part?
Any video clips, live surgeries, video clips?
Any video, any.
This moment we haven't. If you have interest, next time, not next Friday, because she will leave. Maybe after 1 month we will prepare this material. You have interest for subluxation, yeah?
Yeah.
Like rheumatoid hand.
Okay.
And next time we try our best. We will prepare some video in the intra surgery. Very sorry. Just now, Andrei inform us must be finished.
Also, the configuration for syndactyly with the fingers are fused. The mini Lizaro configuration.
Syndactyly. Wo.
You have, you want this presentation about syndactyly?
No, you. She will present syndactyly by Lizaro.
Yeah, excellent. Yeah, excellent.
Okay.
Next.
That's
Okay,
good,
thank you.
that's good.
You talk.
Thank you.
Next Friday, what will
Thank
be?
you.
She's giving next Friday.
Next
No,
Friday,
thank you,
you
thank you
Indian
very-
doctor.
Huh?
Next Friday, Indian doctor. Yes, syndactyly.
India will talk syndactyly. No.
Okay, sir. We'll manage that in the coming Friday. Hope we can arrange that also. And thank you very much. I would like to thank Professor Natalia ma'am and Professor Novikov sir, as they have to move forward for another lecture. So I would like to say bye-bye to Professor Novikov sir and Professor Natalia ma'am. And it's a great day for us, as we have two learned experts from the mother of Elizarov, that is we call the Kurgan, Russia, and hope we'll see you in the coming Friday with another Elizarov topic. That is the magical Elizarov that helps us lots in case of many challenges, challenging cases, and hope we can discuss about syndactyly in the coming Friday. We hope so, but we are not sure about that. But we will try our best to present syndactyly in the coming Friday. Till then, I'm Dr. Mohammad Tanvir Ashraf saying bye-bye to all of you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.